global health ethics team. And as some of you might have heard, for a few months now, we have been working on WHO guidelines for ethics and governance of AI for health. And I'm very thankful to the organizers that have invited me to join this meeting. And they have asked me to share this last session, which is a very interesting mix of speakers again, very interesting panel. But we will have not have with us Wagner Meira Jr. From Brazil. And that's why the organizers have asked me to speak for about 10-15 minutes about the WHO project on ethics instead. And I would like to start with doing that. So normally I will start my presentations with a few slides on all the opportunities that AI is bringing to health, from clinical care to public health, from diagnostics to treatment. But I thought in this audience, this is actually not needed. I shouldn't be preaching to the converted. You all know about the many different and promising opportunities that AI brings to health. And some people say this is actually revolutionizing clinical care and public health already now, and latest within the next decades. At the same time, as you all know, AI poses potential risks and even ethical dilemmas, which health policymakers need to address in their policies, in their regulations. Just to name a few things, one that is often mentioned is the bias in algorithms, in the design, even maybe in the data that gets used in the computing, which potentially could lead to discrimination in healthcare. A second point is the private sector, the roles, responsibilities, and accountability of companies and their interplay with the governmental sector, which has been pointed out as a particularly difficult issue here. Another example, and that was already mentioned, is patient rights such as autonomy, privacy, and informed consent, which are not new issues, but are especially complex if we're talking about transporter data sharing and using different data sources, which come from different jurisdictions. And then finally, there is, we know, a digital divide existing within countries. For one, there are some populations that do not have access to digital technologies as much as other populations. There's also different types of literacy in terms of technology and also health. But not only within countries, but also between countries, we see quite a big divide. And there's a fear that actually the technological advances will benefit some countries more than others, and maybe the digital divide could even be widening. So this is clearly a risk on the horizon if not appropriate actions are taken. This is why for a number of years our global health ethics team at WHO has been working in this area. So initially in 2017, we organized a WHO consultation on ethics of big data and AI for universal health coverage. We then had a special symposium at the World Congress of Bioethics in Bangalore, 2018. We are at the moment publishing a special issue of the WHO Bulletin on machine learning, big data, and AI and ethics, which will come out yeah, thank you. In early this year, meaning in March or April. And then finally, this is what I'm going to talk about more, is that we started in October 2019 to develop guidance on ethics and governance of AI for health. This is very much a joint project of our global health ethics team and the newly established digital health department at WHO. I think the final title, we've been transformed repeatedly. I think the final title is Digital Health and Innovation Department. And we have convened a group of international experts to formulate guidance for the member states by the end of this year. This is, as usual at WHO, a quite mixed group of different expertise, from ethics, from philosophy, from computing, from technical AI experts, but also industry, government, and other international organizations, because we are fully aware that WHO is not the first organization to work on these. Other sister organizations as UNESCO, OECD, the Council of Europe, have all already been working on ethical and legal issues of AI more generally, but not so much with a focus on health. But all this work is, of course, the foundation for WHO's activities in this area. The co-chairs of this group are Partha Machunda, who's the president of the Indian Academy of Science, and Professor Effie Vallina from Zurich ETH in Switzerland. So the overall goal is to develop an ethical framework for AI for health that will frame the oversight, development, and use of AI across healthcare and clinical health, but also across global public health. And then this framework hopefully will also inform the development of governance option, including the enforcement, compliance, and where such principles will apply, including more concrete case studies. And the group should also provide WHO with recommendations beyond this completion of the ethics and governance framework. On the 2nd to the 4th October last year, we had the first meeting of this group, and we received testimony from different stakeholders, notably the industry, but also clinical medicine, public health experts about different use cases, and have a comprehensive picture of the possibilities of AI in health. We reviewed key ethical issues in relation to AI, and I started to identify some ethics principles, and then finally discussed the way forward with this project. There was a lot of discussion. This was the initial meeting, sort of a scoping meeting, collecting information on the technical side, but also from other organizations, as I had mentioned, as to their previous work with, which is relevant to WHO's project. And there were a few areas of consensus that already emerged in this first meeting. The one was what should be the nature. The question was what should be the nature of this WHO guidance document, and some were arguing for more of a conceptual, high-level principle document, maybe some kind of 10-point charter amendments type document. While others were insisting that actually the member states need something very practical. And I think that's where actually we reached consensus in the end, that there should be more pragmatic guidance including with case studies and use cases if this document should be useful. And then there should also be guidance on this question of the digital divide and also the investment case, because, of course, for lower and middle income countries, there is a big question. Is this all a luxury? How much should we actually invest in this maybe future technology or on the horizon when people are dying every day of, infectious diseases, which would be very cheap to treat? So there's this ethical question, of course, what are the opportunity costs in investing in this technology now? The guidance should be not only tailored to the short term, but also should be forward-looking, although the experts recognized that this was going to be particularly difficult in this very fast-moving area, which is maybe not, how to say, typical for ethics otherwise. Ethical principles are usually not very short-lived. But in this area, we're really dealing with a fast-moving target, and that was recognized as a particular issue that needed to be kept in mind. Then fourth, this effort should not start from scratch. As I said, we can draw on a lot of existing laws, policies, human rights protections. And then lastly, WHO's documents usually are targeted at the ministries of health. That is our primary target audience. But in this case, it was recognized that there are many other stakeholders, so other ministries, science and technology, but also the treatment providers, the doctors and nurses, patient groups, and especially also the private sector and industry, which should be included in the target audience of this document. So all in all, quite a complex undertaking as compared to other projects and documents that we are working on, I have to say. But these were sort of the main points that came out of that first meeting. And just to show that, for this meeting, as I said, we took stock of what is existing. And this is one publication, but there are several others from China and so forth. There are probably around 100 sets of principles for AI now. But what we found is that none focus specifically on AI in health so far, and that most principles were developed by individual stakeholders and mostly from the global north. So what we are lacking is actually a consensus around principles and also specific principles for AI for health. Now, another question we debated is whether it's actually makes sense to have specific principles for AI for health, for whether actually, this is just one small sector and we have to sort of incorporate all the other principles from the bigger AI picture. Again, that is for the moment not really solved, I have to say. There's ongoing debate on this. Now, we're already gearing up for the second meeting, which will take place 5th to 6th of March in Copenhagen at the WHO European office. We will invite further experts from other areas that we couldn't discuss at the first meeting, for example, wearables and genomics, but we'll also try and have more input from healthcare providers and patients and the public. And we'll discuss a few more legal issues, including ownership and liability questions, and also the relationship of the public and private sector. And then there was a suggestion, should there be a digital patient bill of rights? That was maybe from the faction that this was more for a short and crisp document from WHO. Again, this is still on the table, needs to be discussed a bit further, what could be, and I'm also looking forward to your feedback on ideas like this. Would that potentially be of any use for the governance in the future? And what I should say is that this meeting is also open for observers. So if any one of you would be interested to attend this meeting, please contact me or one of the chairs here, get in touch with us, and that should be possible. The only thing is we cannot cover your travel costs as an observer, but we're very open to participation. I would like to very much thank my colleague Samir Puchari, who many of you know because he's one of the co-chairs here. He has really been sort of my link and focal point in the digital health department. We're doing this very much together. And then my other colleagues, especially also the WHO expert group on ethics and governance of AI in health. And yeah, I think that really says it all from WHO's standpoint. I think we really must find a way forward that AI will benefit the people, including in LMICs, and that the digital divide will not widen. Thank you very much.
Can I maybe add to why specific ethics thing for AI? AI is, as we heard earlier, AI is creating new degrees of freedom. We had a submission once to one of our meetings to predict, based on lifestyle data, a potential opioid addiction in the future, and which is a new degree of freedom, something to be able to do that. And for that, there needs to be some very practical guidance on the ethical situation. So that's why I think the degree of freedom AI provides may require specific AI-related ethics documents.
Okay, thank you very much for that comment.
Yeah, thank you for your presentation. Really interesting to see you actually, because we had lots of talk in the focus group already about ethics, and I don't know, I'm just happy that this is now really, like, taking shape. And I also have many questions, so I try to boil it down to three. So first one would be, I mean, there is this issue of different norms, right? Or different. So my I assume you don't have the answer yet how to reconcile this, but maybe I would be curious, what is your strategy? Are you trying to have a framework that fits all different regions where maybe different norms reign, or do you have some other approach? So what is just like the strategy to address this? The second one would be at what level of abstraction these recommendations or principles will be. So what is your, again, like your plan? Is it the principle, or do you also give some guidance on how to translate these principles for AI solutions? Because I think this is also a big challenge often. And then the last one, I'm just curious, so how this works as an ethics expert. So do you use formalisms? I mean, I know as a lay, like, interest person, there are some ways to formalize ethical problems. I don't know if it's the best way to approach ethical problems, but it's for sure it makes transparency possible. So is this something that you will I don't know, like utilitarian or Kantian moral philosophy, I don't know, like, do you use this kind of framework, or how do you come to these recommendations? So
yeah, thank you very much for these excellent questions, which have mainly to do with how international ethical norms are created. And yeah, these are all very pertinent questions. The first one has to do with what some people call the universalism, universal norms versus particular norms in a country and culture. And that is actually one of the main difficulties how can you create international ethical norms that are actually acceptable by everyone? The thing is that what we see is that actually most cultures do converge on very broad level principles. It's more in at the translation of these principles, as you were saying, that there will be differences, and also in the weighing. So most societies would, attach some kind of of worth to privacy and also to equity. But maybe in some countries, privacy will be of a sort of higher weight than equity and solidarity, for example. But the general principles actually are quite universal. And that gets me into the level of abstraction. And so actually we do want to formulate global norms that everyone can agree to. But we also want to have examples on how these norms can be or should be translated into practice. So the consensus of the group was we shouldn't stop there, just having another set of principles. We should indeed try to make this very concrete with, for example, use cases where the ethical dilemmas are discussed and then guidance is given. In this case, for example, we should do A, B, and C as a government or as a ministry. And yeah, in terms of the ethical theories, as you say, there are many. Utilitarianism, Kantianism are the most important ones. We are actually at WHO neutral. We don't subscribe to any particular theory. We also say eclectic in a way. But it is important in the composition of the expert group that you actually have a quite diverse group of experts, not one that is sort of too much wedded to one particular ethical theory. So this is taken into consideration in the formation of the. Okay, if there are no further questions for the moment, I think we also, in the interest of time, have to go on. It is my pleasure to introduce the next speaker, who is Alexandre Ciavigato Filho. Sorry for the pronunciation.
And politics. About ethics, that is very, very important, and politics. What do you think about? What is the relationship about this kind of movement, the science and the states, the national states? What kind of formalism that you're going to produce? Because it's a real wealth politics, isn't it?
Yeah, thank you very much. This is a huge question for the whole evening over dinner. I don't think I can even try and start answering this. And I'm also told that we should keep on time. Maybe we can come back to it in the panel discussion, I would suggest. Okay. If not, are you here tomorrow as well? Okay, I will find you otherwise, because this is a very long question. Okay, so I would like to ask Alexandre Ciavigato. Is he here? Do we know whether he's here? Okay, please. And we'll.
No, it's not. Just your slides, are they available? Because it's not a part of the program. Can we have access to your slides too?
Absolutely, absolutely. You already have them. Just share them. Okay.
So, thank you very much for being here and for the invitation. So my name is Alexandre. I'm a professor of machine learning healthcare at the University of São Paulo. So I'm going to talk a little bit of about what I do and some of our most recent results at my lab. So my lab is the laboratory of big data and predictive analysis in health. And even though we have a major science crisis now in Brazil, we are fortunate to have the backing of some of the most important funding agencies here in Brazil. So one of our first questions, our first challenges in our lab was predicting risk of death, which historically is one of the biggest challenges that we have in epidemiology and health sciences ever since the life tables of John Grout in 1662. And we showed recently on a tutorial which was published in Caderno de Saúde Pública, which is an important journal here in Brazil. And it's the first tutorial in Portuguese about machine learning in healthcare. We use as examples exactly this, predicting deaths among elderly residents of São Paulo. And we show that even with very little data, we're able to have very high predictive performance in terms of mortality risk. And we just got access to a very large longitudinal study, and we are very we are very optimistic that we're going to be able to predict not only that, but cause of death in the future using elderly patients. Another recent result that we got was in a very hot area now in medicine, which is palliative care. It is this thought of should we keep aggressive interventions in patients up to the last seconds of life, or when patients are on terminally ill states, wouldn't it be better for them to start focusing on quality of life? But the biggest issue in starting palliative care is getting good prediction of that. So of quality of life. So you don't want to stop treatments that are going to give the patients plenty of time, plenty of quality of life in the future. So we were contacted by a major hospital in Brazil that told us exactly this, that they're starting to try palliative care, but they're very wary of the predictions that they're making in terms of survival of the terminally ill patients. And they wonder if we could train some machine learning models, and we are very happy to help them. So we used, again, it's not a large sample, but it's a real sample from São Paulo. And the results from this study surprised us and surprised our partners. We were able to predict with very good calibration which patients were going to die in less than 30 days, or we're going to have less than 30 days of quality of life, which is a little bit different. It's much more interesting, this study, than the previous one. Because here we're predicting quality of life using quality, which is an indicator of quality of life. And we are able to predict pretty well, not only who's going to have less than 30 days, and why 30 days, because our partners thought it was a good time to start thinking about palliative care if the person has less than 30 days of quality of life. We were able to predict very well and to get the probabilities right. So we had a very good calibration here, meaning that when our algorithm said that the person had very high probability of having less than 30 days, for example, 90%, we would check, and among the people that the algorithm said that it was 90%, we would check, and among those, around 90% of those would end up having less than 30 days of quality of life. Here, the straight line is the perfection, and the dotted line is our algorithm's performance. So it was, as we call it, a very well calibrated study. And another one another recent one that I want to mention was one that we tried to tackle one of the biggest issues we have, the biggest difficulties we have in health, which is to accurately find out good public health practices, public health practices. And why is this so hard, especially in a country like Brazil? It's because socioeconomic factors matter so much. Okay, so if we do a ranking of life expectancy by municipalities in Brazil, we end up with a ranking of rich cities, pretty much. Okay, so our challenge here was see, can we predict life expectancy of each municipality in Brazil using only socioeconomic characteristics? And I'll show you that we were able to do this quite well. And then we got to a more interesting part, the second part, which is to look at the municipalities that our algorithm gets wrong. Okay, so municipalities that overachieve, as we call it. So municipalities that do better than is expected according to our algorithms. Okay, and then we started looking finally at health characteristics. So what are they investing in healthcare differently from the other municipalities? So first of all, again, our algorithms, and again, this is results of tests. This is test results. We always only show the test results, which it's what really matters in machine learning. So here is the prediction, the y-axis. So when our algorithm says that using only socioeconomic characteristics that this municipality should have a life expectancy of 77, we check and it's around 77. If it says that it's medium, like 74, we check and it's medium. If it says that it's low, we check it's low. So in general, it had a pretty good calibration using only socioeconomic factors. But it got a couple of municipalities wrong, or a lot of municipalities wrong, and we started looking at what these municipalities were investing differently in healthcare. So what we found was pretty interesting, and this study was published in Epidemiology, which is an interesting journal in our field. So we found in the end that the municipalities that were doing better than predicted by our algorithms were the ones that were investing more in primary health. So they had more childhood vaccinations, they had more Estratégia da Família, which is our biggest primary care project we have in Brazil. But the other interesting result was that underachievers, meaning municipalities that are the worst that our algorithms predicted, also had some better health indicators, but all associated with secondary health care. So our conclusion here is that everyone is investing in health. We have a floor, we have a minimum investment in healthcare in Brazil, but some municipalities are investing in areas that give more in terms of life expectancy. We have a few other studies in our lab, and I'm happy to talk about it if anyone is interested, to talk further about this if anyone is interested. So we're doing mortality prediction for patients with yellow fever, and we're getting very impressive results here. We're almost publishing this article, which yellow fever in Brazil, we had an outbreak last year, which got up to the big cities in São Paulo, which is something new. And we're able to predict with the characteristics of the person that gets into hospital who's gonna die in 2 weeks. Okay, and it's a very impressive performance we got here. PTSD after natural disaster. Natural disasters have been growing in importance in Brazil. We had some issues with Brumadinho, Mariana. So we're able here, it's a partnership we have with Harvard and with Japan. We're trying to predict after the tsunami in Japan, who's gonna have PTSD. Okay? Gestational age prediction, another very important topic here in Brazil. We have a huge number of C-sections, a proportion of C-sections in Brazil. Brazil is one of the world's with highest percentage of C-sections, meaning that a few of those babies are getting born before they should. So here we're trying to predict how many days, based on the mother's characteristics and the fetus characteristics, how many days is expected to help doctors into deciding the better date for the C-sections if they have to. Prediction of diversity results in medical exams, another partnership we have with the University Hospital of the University of São Paulo. We're trying to help physicians into deciding priorities in which exam to choose for each patient based on the probability that this patient will gonna have a bad result for this exam. Cognitive decline for elderly patients, another one. And last, this is a very interesting study of one of my PhD students. He's finding hotspots of anomalous cancer incidence in Brazil. So he's trying to predict how many cases every municipality of Brazil should have of cancer. And again, we're predicting really well, but there are some municipalities that will predict really bad. And we're starting in the next phase. We think that it's probably going on some environmental contamination so somehow in these municipalities, which are very close and very and are having much more cases than our algorithms predicted. End to end, we're just launching at the University of São Paulo, the biggest center of artificial intelligence in Brazil. We got a pretty good funding from IBM and from FAPESP. And we have 3 main areas, and one of them is healthcare. So we're very excited about this. We're going to launch in the next few months this new initiative, which should be quite important for us. And well, in the end, the most important thing that we have in machine learning is human capital, and I'm extremely fortunate to have an amazing team, and we are always looking amazing team of master students, PhD students, postdocs, and we are always looking for new data to try the algorithms, new partnerships. So if you think you have an interesting data set, or you're interested in collaborating with us, we're very welcome to new partnership all over the world. So thank you very much. Should we open questions? Yes.
Thank you very much for your talk. I'm Abu from RKI. I've been wondering, first, which kind of neural architecture did you use for the prediction?
So we use structured data, usually data from clinical results or from surveys. So we use gradient boosted trees, we use random forests, neural networks, logistic regression, and we often try deep learning, but it doesn't work so well with structured data. But we usually try 10 to 15 different algorithms, but usually the best ones are gradient boosted trees, random forests, and simple neural networks.
Okay, and the other question is, you reported the area under the curve as performance of your algorithm.
Yes.
However, you probably need to communicate this to physicians, and they probably don't know what that means.
Yes.
So what are other metrics that you communicate?
Yes. It's why we like the graphs. So, I mean, the area under the curve here was 0.82. Well, it's not great, but it's pretty good. Giving into consideration that we only have 777 patients, which is a very small number, but usually the physicians understand pretty well the graph. So yeah, usually in our studies we get an area under the curve always over 0.8. Otherwise, we won't probably move forward with this because we have so many things going on. But on the yellow fever, I think we got 94, so it's pretty high. So it depends on the study, but we usually when we communicate the results, we usually prefer the curves. So area under the curve doesn't mean anything for tissue.
Because my colleagues are always specifically asking for specificity and sensitivity, but apparently that
yes.
already suffices.
Yes, on the articles we have that too. Yeah.
And the last question, just out of pure interest, why does Brazil has one of the best C-section rates?
Oh, this is a very area of a lot of discussion in Brazil, but it's pretty high. It's over 50%, and it's been like that for a long time. It has some justifications, like usually because the physicians prefer that, and there are a couple of researchers on this. Like the mother starts the pregnancy wanting a natural birth or a vaginal birth, and then in the middle somehow she gets convinced that C-section is better. So usually the studies point out to the fact that the physicians usually prefer that because it's more. You don't have to wake up in the middle of the night and so on. You get to have a whole team ready for this and so on. And because in Brazil, it's a pretty much loose. And another justification is that it paid better the physicians also. Up to a couple of years ago, I started changing this on purpose because of our results. So I mean, you don't have one thing; you have a lot of things going on. But it's an area of debate still.
Thank you.
Thanks for the very interesting presentation. I was just curious, the work that you're doing on PTSD and natural disasters, besides tsunami, are you looking at any other types of natural disasters? And what kind of data are you using as an indicator for the PTSD?
Yes, so it was a study that was getting done in Japan, and out of coincidence, the tsunami hit straight after. So our colleagues went back there and investigated the region with mental health questionnaires and so on. The exact same people, of course, the ones that were found, were re-interviewed. So we were able to, based on baseline characteristics, to train machine learning algorithms to learn the risk of each person have a PTSD. But we haven't tried it on new samples yet. We're still working on this. We got an abstract that was just sent to a congress, and we're working on the article. So it's still not finished. Okay. One more question, is possible? One more.
Hello, thanks a lot for your interesting talk. I've got a question concerning the 30-day quality of life prediction. How do you measure the life quality for cancer patients? Because I think it's very individually, it depends on the kind of cancer. So how do you measure that?
We use QALY, which is an indicator of quality of life that takes into consideration mental health, mobility, how you're able to do usually life stuff and so on. I think the World Health Organization uses it a lot. So yeah, we use that just because it's the most used indicator internationally. It's easy.
And you and the patients, do they also get to know the prediction, or is it only for doctors to plan
in the future, we hope that everyone will know it. So I think we are probably going to give it to the physicians, and the physicians is going to decide if he brings this information to the patients. He probably will, because it has to be a group decision between the physician, the patient, and the family probably. So yeah, but our idea is to give this always to the physician, and he will decide what he'll do with this in the future, because we're not ready to put this into production. We're just showing that it's feasible, because our sample is still really slow. It's still really low, only 777. We can get a much better performance if we get more data, more people. So this study only shows that it's feasible. That's it.
I know there are many more questions, but we are a bit short of time. We can come back to these at the very end. Let us thank again Alexander for his excellent presentation. It gives me great pleasure to introduce the next speaker, Mario Barbe Abrigo, de la Clínica Alemana de Santiago in Chile.
Hello everyone. So this is a more technical description of a study, and it's the evaluation of an automated bone age estimation method. Disclosure, I've been employee of the University of North Carolina at Charlotte, Universidad del Desarrollo, and Clínica Alemana Santiago. So why do we want to estimate bone age? Bone age is a measure of how much a child has progressed in her skeletal development. Skeletal maturation is controlled by hormones, which are the same that influence the onset of puberty. Bone age estimation is part of the evaluation of patients with conditions such as delayed or precocious puberty, short stature, or abnormally rapid growth. How do we measure bone age? Traditionally, we evaluate the left hand using one of these popular methods, the Growley-Hand-Pyle Atlas, or the Tanner-Whitehouse method. Why the left hand? The right hand is more likely to suffer more injuries than the left hand because most people are right-handed. This definition was made in the early 20th century. The Growley-Hand-Pyle is the most popular method among pediatricians. The method consists of an atlas in which bone age is assessed by comparison of a patient left hand X-ray with the closest standard X-ray in the atlas. This atlas was developed using X-ray of Caucasian children in Cleveland, Ohio, United States between 1931 and 1942 and revalidated in 1988. Why do we want an automated bone estimation method? Evaluation with the Growth and Pie Atlas can take around 2 minutes to complete. The confidence interval are bigger compared to the Tanner Whitehouse 2 method, as we can see in the table. From minus 2.46 to 2.18 years using the Growth and Pie, while with the Tanner Whitehouse 2 method is smaller, as we can see, about 1.42 to 1.43 years. But Tanner Whitehouse is more time consuming than Gray and Pile, taking nearly 8 minutes to complete. So we decided to evaluate an automated method as an alternative to our traditional method. In this case, we evaluate a bone expert solution. The system analyzed the images in our packs following 3 steps. The first, bone borders was reconstructed and validated. Second, bone age was determined and validated for each bone. And lastly, an average of 13 bone age was obtained, and that number was adjusted to Gurley and Pyle method. Bone expert has some limitation. For example, it only validated on boys from 2.5 to 17 years and 2 to 15 years for girls. Also, the software automatically rejects images with poor quality, like lack of contrast or abnormal bone morphology. So our protocol to evaluate the correlation of bone age assets using a manual Gurley and Pyle atlas versus automated assessment using Bone Expert consists in an observational study. The setting was Clínica Alemana Santiago, which is a 440-bed hospital performing roughly 30,000 surgeries per year. More than 1,400 specialists work at Clínica Alemana. We obtained 1,500 consecutive anonymized carpal X-ray. The bone age was determined by Gurley and Pyle method by one of our 7 pediatric radiologists for each carpal X-ray. Only children who were under 16 years between January 13 and January 16 were included in this study. And to evaluate and to see the results, the results were that 7 cases were excluded automatically by Bone Expert. The analysis showed that the X-ray contained the finger of the technologies or the parent project radio or Bone. So from the 1,493 cases, 61.1% were girls and 38.4% were boys. The median age for girls were 9.96 years, with an interquartile range from 8.51 to 11.29 years. And for boys, the median age was 11.12 years, with an interquartile range between 8.72 to 12.71 years. The correlation among the different rates was very good, was 0.91 to 0.93. The average difference was 2.2 months, with a confidence interval of 1.56 to 2.99 months. But the average sometimes hides information, as we can see in this scatter plot of girls' bone age, where the bone age determined by the radiologist is on the x-axis, and on the y-axis, the Bone Expert bone age. In some cases, there were high discrepancy between the pediatric radiologist and Bone Expert. In this case, particularly, almost 9 years. What we found was the extreme different weight cases with suspected genopathies. So what do pediatricians prefer, at least in our center? It depends on the pediatrician age. Younger pediatricians prefer bone expert mainly because it's return a smaller standard deviation, whereas more experienced ones stick to the Grudem pipe method because they understand how the result was calculated and feel more confident with a human evaluating the bone structure. Thank you so much. So
thank you very much, Mario, for this very interesting presentation. I have to say I felt also that my bones have aged a bit when I got off the plane, but I know it's not for adults, only for children. We will go on with the next presentation, also from Chile, and this is Milan Vidara. ENIACs.
Okay, so good evening or good afternoon. I'm not sure. We're here all day. Everyone, how do you feel today? It is one weird question for start this presentation, and I put these numbers on the presentation just for show that the problem is big. I don't like to. I would like not to talk about this number. This number is prediction that healthcare costs in the next 10 years will go up to $47 trillion. And we are talking about here the mostly what we were talking about here today was the patients that have for at least one chronic disease, and we know that is like little more than 50% of the whole human population. And those are the patients that need a constant care, right? And in the other hand, those are the patients that came in touch with the healthcare system when they feel ill, when they need to go to ER, and that is quite a problem. And we heard about lots of good solutions here that tries to improve the access of the patients to the health system. But healthcare is partly about care, and there are studies that show that there are only two good ways to show someone we care. First one is reach out, ask them how they feel, ask them what they need, or ask them what was their problem, how they day was. And the second one is described in this Chinese word, and it means listen from the heart. In healthcare industry, only $7.5 billion is spent on contact centers and communication with the patient, and all of that is a communication that comes inbound. It's basically we are answering a patient's call for help. And why don't we talk to the patients in outbound manner? Why don't we show we care? Because it's too expensive. Communication one-to-one with the patients costs much more money than $43 trillion. So that's why in ENIACs we created Patricia. Patricia is artificial intelligence that combines machine learning algorithms and trained models to decide when and what to communicate to the patient, and very powerful natural language processing engine that understands what is that the patient says in return. It does understand the patient's response. So, but Patricia is not a bot. Patricia is exoskeleton that is used by our staff that we call coaches, that are the people with some sort of medical background. And with the help of the coach, Patricia is able to communicate to the every communication channel we know today. It communicates through an email, it says WhatsApp, SMS, it even calls people of the phone, on the phone, it talks to the Facebook Messenger, etc. So we started in a laboratory. No, we didn't get the government financing to start in laboratory in the clinic. That was our first client. It's called Clínica d'Ávila. Clínica d'Ávila is largest private health hospital in Chile, and also it attends the people with mid-low income. So their prices are basically like 5 times lower than prices of Clínica Alemana, for example, which is which is a very good example. So the costs of the operation is very important in that clinic. And we started with a simple task: confirmation of the patient appointment and reminder of the patient appointment. So because that is something that is go against the no-show, which is a global problem. Like no-show and average in the whole world is around 20%. And if we add all other time that doctor is doesn't do what, doesn't see the patient, we have like 40% of the doctor's time spent out. We started working with the contact center of the clinic closely, and we created a model that had like 85% of certainty, and we started that in production. It wasn't ideal, but we had something. So in the first month, what we did is that we lowered the no-show by 50%. And also we raised the occupation of the clinic by 12%. By communicate with the people through a simple email. Patricia was sending emails like a man, like a person, and the people responded. And the bonding that we made with the patients was made precisely because Patricia was not a robot. Patricia was improved service. So we also could respond to these questions like, where should I pay for my appointment? Which floor is doctor attending, etc. And also, can you move my appointment for another day? So we also raised patient or customer satisfaction up to 9%. And the bonding was that good, that strong, that we had examples of the patients, of the people, sending questions to Patricia from the waiting room, having a real person in 3 meters from there. Of course, we had problems, and Spanish can be quite complicated. For the Spanish speaker, it's easy, but no confirmo y no coma confirmo means totally different things. So Patricia made mistakes. With 85% of certainty, it made mistakes. It canceled some appointments, and obviously we face this. Everybody was against technology. Everybody saw that as a black box that makes mistakes and causes troubles. Everybody wanted to review every answer to every patient that Patricia sent, which is ridiculous because it's even more expensive than doing it only with humans. So what we did is we make responsible for the whole process. We were the ones that we will receive patients in Clínica d'Ávila. We explained the problem. We received the doctors. we explain why the patient didn't came, etc., and everything that help us to build a better service. Right now, Patricia is trained to follow the patients to the whole journey. We have a couple of applications and sockets and other and couple of widgets that allows patients to book appointments with predictive overbooking, which helps against the no-show. And we also help some patients before and after the appointment. After appointment, Patricia communicates with the patients, asks how the appointment was, if there is some control or some exam that they had to do, so she helped to schedule, etc. And what we are piloting right now is proactive preventive communications with the patients, and also the follow-ups of the chronic patients and medicaments and those stuff. Right now, Patricia works for like 99% of the children market of the biggest health providers, including Clínica Alemana, Clínica Las Condes, and we have operation in Argentina, in Peru, and Spain. And Patricia right now is talking with a little more than 3.2 million of the patients every month with help of 5 coaches, only 5 people. It started like a small dream. There are 2 of us right now. We are more than 20, multidisciplinary team, and we believe that it's possible to show that machine with a little help of the human, show that it care. I guess I'm not that good in presentation, so I would like for you to listen how Patricia is doing that.
Aló.
Aló, hablo con Julio Rojas.
Sí, con él.
Buenos días, Julio. Te habla Patricia de Clínica Dávila. Quiero confirmar su hora de mañana, martes a las 4, con el doctor Daniel Fernández. ¿Va a asistir?
No, no puedo.
Ningún problema. Voy a anular entonces su hora de mañana, martes a las 4, con el doctor Fernández. ¿Le gustaría reagendar?
Sí, por favor.
A ver, deme un segundo. Ya. Las próximas horas disponibles del doctor son miércoles a las 3, viernes a las 11 y viernes a las 3 en la tarde. ¿Puede a alguna hora?
El viernes a las 3.
Perfecto. Entonces su cita queda agendada para el viernes. ¿Algo más?
Nada más. Gracias.
Muchas gracias por elegir la Clínica Dávila. Adiós.
And for the end, I would like to leave you with this message. This is a response from the real patient from Clínica Dávila. This is something that makes us wake up in the morning and go to the office and work hard to make this possible. Thank you.
Thank you very much, Milan, or should I say gracias, Patricia. We will have the questions in the end. I know there will be many questions. We have one last speaker today, last but not least. It's Jonathan Tirado from the University of San Marco in Peru. Please.
Good afternoon. I am thankful and honored for being invited to this event. I am representing my university and my country, Peru. Today, I will present the winner project for the 2019 Artificial Intelligence Contest. This was organized by the e-Government Network for Latin America and the Caribbean region. It was sponsored by the Inter-American Development Bank and the Organization for American States. This contest, the goal was to generate and come up with solutions, artificial intelligence solutions, for improving the quality of life of the citizens in the region, in Latin America, in areas like security, transportation, health, for instance. So my team thought an artificial intelligence solution would be very valuable and also have a very high impact in the public health sector. I already heard this, but in Peru it's also the same problem. We have a physicians to inhabitants ratio lower than recommended by OECD. Even worse outside the capital city, which is Lima, and in some regions like the Amazon, some cities you can only get by boat, by the river, or by plane. So doctors, physicians, they don't want to work or live there because those are isolated cities. So that's a problem. Access to specialists, access to health. The consequence, already mentioned here by other speakers, long waiting times in public hospitals, long queues, not enough specialists. So that's a big problem. And for those reasons, I can say that public hospitals don't have enough capacity to provide a high quality and timely service to the population. If you want an appointment with a specialist, you have to book that 1 month in advance, maybe, if you are lucky. It's not an exaggeration, but you could get worse, your condition could get worse, or you could die waiting for an appointment with a specialist. So for this contest, my team thought about proposing an artificial intelligence solution for health. We came up with this. We proposed a software application for cardiopulmonary diseases diagnosis. It uses an artificial intelligence deep learning model to diagnose up to 14 diseases. For example, pneumonia, infiltration, consolidation, cardiomegaly, etc. Some of these are common in Peru. Pneumonia, for example, and they have a high death rate. Here you can see some images of X-ray, chest X-ray from a data set that I will talk now. So we used the chest X-ray 14 dataset. Some speakers already mentioned that. Yes, we are aware that there are some limitations with the dataset, but the model was trained on this dataset. It has more than 100,000 images, chest X-ray images. It was collected by Professor Wang and his team at Stanford University. There's a research paper about this dataset. But at this point, I want to emphasize the following. It is very important to have a high quality, reliable, and big enough dataset for training and building artificial intelligence models. Thus, it's required to have to set public policies, standards, frameworks, and protocols to collect, transport, secure, share, and use this data, because it's very important, very valuable, and also you have to, it has ethical considerations and privacy considerations. As you know, big, huge amounts of data is required for, usually for artificial intelligence, machine learning, and in this case, deep learning. Also, it also depends on the nature of the problem and the prevalence of the disease you want to predict or classify, for example. And it's also harder to build a data set for medical images, for medical diseases. It takes more time and it's more expensive than in other domains. If you want to apply deep learning, machine learning to recognize the license number of a car, that's easier, but if you want to apply this to health, it's harder and it's more expensive and time-consuming to build a data set for health. Well, on the technical part, on the technical side, we use a deep learning model based on the DenseNet 121 architecture, using convolutional neural networks. This type of neural networks is specialized in image analysis and pattern recognition. So that's why we use this. And how our project works. It's very simple. You upload a chest X-ray image to the application. The model, the artificial intelligence models, processes that image and gives you the probability of those 14 diseases. Like in this example, infiltration is the one that has the highest probability for this patient, for this X-ray image. Also, this can be a mobile application. It can be on the cloud also. But the takeaway, the conclusion is the following. We can build artificial intelligence solutions for health. There is huge potential, but we need to be aware of the challenges and set policies to guide implementation of these solutions with one goal in mind: improve the quality of life of our citizens using this kind of technology. Well, this is my team, the X-ray team. We participated last year in Buenos Aires, Argentina, in this event. They are Henry Medina, Denis Malki, Josimar Chiri, and Miguel Cotrina. Thank you very much.
Thank you very much, Jonathan. I know we're out of time, but I also know that there were a few questions still, so we will open it up for 15 additional minutes of questions to all the panelists. So I would like to ask Milan, Mario, and Alexander to come forward again. Please take a seat. And yeah, I think there was one question already there. Do you have a microphone?
Well, my question is for Alexandre. Regarding the efforts to forecast the week of delivery, I have two small questions. what sources of data are you using? What kind of variables are you using? And also, what's the level of precision that you currently get in the effort focused the week of the meeting?
Yes, thank you. We are using a follow-up of pregnant woman from São Paulo, and we are using everything that this study had. We haven't finished yet, so I cannot give you a predictive performance. But we're trying to actually to predict days, so it's a little bit harder than predicting weeks. We started with some preliminary analysis on weeks. That's pretty easy to predict weeks. So we went a little bit further, and now we're trying to predict days. But we have all the consultations, the results from all the physical exams that the woman had on her medical visits. Usually around 6 or 7 prenatal visits.
Thank you. There's another question here.
For, I guess, for the whole panel. So recently, someone asked or say that you shouldn't show doctors an area under the curve because they won't understand. I'm a physician. I'm quite offended by that comment. I think most doctors in first 2 years of their career, they learn about those statistics. And I think it raises a key question is that we are talking about how to validate models, how to make the process transparent. And I think the way we show results is definitely one of the most pressing needs. If you want to replicate a paper and then they only show the very nice outlook of 89, and then if you go into the details, the sensitivity or specificity is not what you would expect, and then they do not report precision recall, and then so for a nice sensitivity, you have several issues with false positives. So in your opinion, what would be the ideal metrics for everybody to clearly understand what's the performance of an AI model, and what's your comments on that?
We usually report every single one of those that you mentioned, and I agree with you that depending on the case, some metrics are more important than the others. For example, predicting HIV, you don't want you want to decrease the number of false negatives because you don't want to incorrectly say that this person does not have HIV, and so the virus will be spread. And on other cases, like in the case of our palliative care, we don't want false positives because we don't want to interrupt the treatment that's going to give this person like months and months or even years of life. So depending on the case, one of the metrics is more important and you should optimize for this metric. The area under the curve is interesting because it takes into consideration accessibility and specificity, but usually want one of those. So we usually present every single one that you mentioned: recall, precision, accessibility, specificity, area under the curve, F-score, pretty much everything. But we have to take into account that the area under the curve is probably it's a very broad one that gives you some metrics. Usually over 0.8 is pretty good, over 0.9 is really good. But we have to think about what is the actual goal of each prediction. So I completely agree.
Yes.
Okay, sorry. Yeah, I will add that correlation is important because if you are trying to replace classic tool, traditional tool, with a new one based on artificial intelligence, you want to know how you compare with the traditional method. So it's always depends on the case that you want more false negative, more false positive. But at the end, the clinician would like to know how this new tool is compared to my old tool and how I can interpret this result.
Thank you.
Yes, I would like to add that I agree with them, with my fellow speakers here. It depends on what's the goal, what's more important, negative cases or positive cases. Depending on that, you want to look at one or other metric, specificity, sensitivity, precision, recall. Well, for starters, it's not a good idea to use accuracy. It's usually bad, but it depends. Depends on the disease. Some diseases are more common than others. Some medical conditions are more common, so that also affects. So you should be careful when choosing a metric. And of course, area under the curve is also a good tool to explain the model performance. But anyway, it helps to see the whole picture and see different metrics, how they behave, how they perform. So it's always good to see several metrics, not only one.
I would like to add something. Everything that we are talking about here is basically like a scientific level or maybe a much more technical level. I'm used to work with a counterparts that are, well, you know, from the clinics. They are usually or gerencia comercial or gerencia operacional. Those are people that doesn't understand this language that we are speaking here. So I think that your question was how to present the results of everything that we are doing in artificial intelligence so it can be understood for the large group of people or basically for everybody. And the way that we are doing that in NEX is that with every counterpart we have inside of our clients, we are establishing the methodology and establishing the KPIs. So they know what results they want to achieve. We know what results we need to show. We need to achieve as well. So I think that the answer to your questions is more like what is the result that we want to show to our client? What is the pain that he has as a client? And North Americans say if the pain is lower than appendix, you don't try to solve it. So when we know what is the pain, we optimize to solve the pain, not to show the results so that everybody needs to understand. That's my opinion. Thanks.
Okay. I want to add something about that. This is not, this is complementary information from physicians. It's the same like Waze. Waze is not taking you to your place. It's giving you some direction and you as a human take decision. And in the lab system, all the doctors can say, okay, this is the score, this is the prediction model. I gonna open what are the lab sums to see if it makes sense to me or not. Still, we are still far away than the machine say, okay, we're gonna take this decision, the other one. This is important. We don't need to think that this system are trying to replace. They are giving another vision and complementary information that we can have better decision based on more information that on our guts sometimes. And I think it's important.
Yes, exactly. And the algorithms usually do not give a decision, gives a probability. Okay, so it gives a probability to the physician, and the physicians use this information and the information he already has in his mind to make a decision. So it doesn't make a decision. That's very important.
I think your response is quite general, because not all artificial intelligence systems are doing what you assume that are doing.
No, I'm talking about specifically what we're doing in healthcare in lab systems. Sorry.
Yeah, okay.
Thank you for your answers. I think that it's good to show clear what you want. Let's say you want to optimize sensitivity or you want to optimize specificity. But I think it's also, it has to be very clear and standardized the way that you show all the metrics, and then, because sometimes it might be misleading. You say, oh, that's a very 95% sensitivity, and then for a rare event, you see that there's a lot of false positives and the precision recall curve doesn't look like that nice. and then they do not show that on the paper. So you have to look deep. So I think towards standardization and accountability of this new technology, I think it's good that there's an agreement on that. Okay, we're gonna show all the metrics, and we're gonna make very clear that we wanna optimize this particular aspect, either specificity, sensitivity, whatever. Thank you.
Thank you. If there are no more questions, I would like to thank again our panelists for their great presentations and also the good discussion now. And yeah, let's give them a hand again. And with this, I would like to turn it back to Thomas, whose closing remarks.
All right. Well, thank you all. This has been a long and inspiring day. We have learned lots of new things that are happening here in South America. Let me repeat again the scope of the focus group. We want to deal with medical devices, with epidemiology, and the health delivery system. Let me again start with medical devices. It became clear that we need standards that help people around the world to develop software as a medical device or as part as a medical device to be quality assured, to be cleared and adopted. That is something that we are getting these requests all over, and part of that quality process or quality safety process is to have the tools available, to have answers to those burning questions. Are my data sourced the right way? Are those data have the right properties? What are the statistical properties? What are the ethical properties? What metrics am I using? Are these metrics fit for the clinical purpose it's being used, etc., etc. So we will try to step by step provide answers to these questions that are surrounding the whole medical device regulation subject. It also includes data handling aspects, etc., etc. So those who are interested in this, I invite you to join us tomorrow and the day after tomorrow, where we will be discussing this area in much depth, because we have, for instance, had a workshop 2 weeks ago, out of which quite a few things came out. The second topic, digital epidemiology, is another topic, and these things are highly connected, although the AI topic is somewhat different, because you are looking at you don't look at an individual patient, but you're looking at a group of patients, or at an entire country or continent or the planet. The whole property with regards to statistics and the questions being asked there are different, but it's also a topic where we see a high need, large need to progress and to bring in new methods and people, and to have also a collective effort. And the third thing is the health delivery system that relates to telecommunications in the health delivery systems, how to transmit data around for AI classification, how to make the whole delivery more efficient. How can you, at the end of the day, download an app into your health system? We have a few ideas that we have been developing and that we are working on as well that we haven't been mentioning yet. One is the idea of a collaborative data collection and data annotation app, where we would basically be enabling parties from all around the world to collect data and also to annotate data. Let me go back to this histopathology example. We would basically be collecting pathology images from around the world, from registered participants. They would be brought to a server and they would be then prepared to be again annotated by a number of pathologists. That way we try to create big collective inclusive data sets that would then at the end of the day be used as a reference for this. And we have been talking to our WHO colleagues who are very much in favor of this and starting to develop this app. Another topic we discussed is public health and virus outbreak systems, and trying to make progress on this topic by bringing together interested parties and academics to basically identify how a better prediction of a virus outbreak, and also as a result of the consequences of certain actions when one faces such an outbreak, are bringing. And there are many, many questions that we haven't answered yet. We'll be trying to have a structured process tomorrow. As usual, we have an agenda posted for tomorrow. We have times where we try to have the various presentations. We do have some option to discuss new ideas, new things. If something comes to your mind this evening, you want to bring it back tomorrow, we are open to discussing what your ideas are. And I hope that we manage to see you again tomorrow, or the day after, and the day after, and for the next meeting. So try to also recruit you to spend part of your life with us. It can be very enjoyable, believe me. Speaking of which, I think, is there something planned after this, or are we closing? Is there a reception? No reception. Okay. All right. So then I'm looking forward to seeing you all tomorrow at 9 o'clock, 9 or 9-ish, 9 o'clock, right? 9:30, 9:30. So see you at 9:30 tomorrow. Anything else? You good? Okay. See you tomorrow. Bye bye.